Greetings and a warm welcome to all the dignitaries present here. I am Shwasika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of ranging services exclusively for the doctors. Clearnet is elated to be chosen as a digital partner for this event organized by Indian Association of Community and Family Medicine. So today's focus would be Alzheimer's building resilience against cognitive decline. So without any much further delay, ma'am, I would like to invite Dr. Ria ma'am to take over. Over to you, ma'am.
Good evening, everyone, to the speaker and all the esteemed participants. And thank you, Clanet. It is my great pleasure to welcome you to this special webinar on Alzheimer's disease organized by the Indian Association of Community and Family Medicine. I am Dr. Ria Roy from IACFM, and we are honored to bring together a community of medical postgraduate students, educators, and healthcare professionals to engage in meaningful dialogue on one of the most pressing neuropsychiatric challenges of our time, Alzheimer's disease. As many of you are aware, India is witnessing a demographic shift with its elderly population growing at an unprecedented rate. This change brings with it an increasing burden of age related conditions, particularly dementia. And a study using the data from the longitudinal aging study in India found that about 7.4% of Indians aged more than 60 years have dementia. And Alzheimer's disease account for like 70 to 80% of those dementia cases. So there may be, according to some estimates, around 6 to 7 million individuals diagnosed with Alzheimer's specifically living in India. So the projections indicate that this number, number of dementia patients could rise to around 17 million by 2036 due to largely India's aging population. Yet awareness about this disease remains low and stigma continues to affect both the diagnosis and care. So the theme for this World Alzheimer's Day 2025 on 21st September is Ask About Dementia, Ask About Alzheimer's. So this reflects a global call for raising awareness towards brain health, highlighting the importance of early intervention and timely intervention, while also reminding us that it's never too late to provide support and dignity to those affected. Today's webinar is especially relevant for everyone who are general practitioners, researchers, and health policy influencers. Your understanding of dementia, both from a clinical and community perspective, will shape how this condition is managed in India in the years to come. We are deeply honored to have our speaker, Dr. Chayan Kanti Manna, a renowned neuropsychiatrist and respected faculty member at ICARE Medical College, Haldia, West Bengal. Welcome, Dr. Chayan. He has done his MD in psychiatry from IMS Patna. He is a receiver of S.A. Hasib Award in 2021, has 15 publications in esteemed journals, and specializes in social psychiatry. Dr. Manna brings with him a wealth of experience in the neuropsychiatric aspects of dementia and Alzheimer's, and his insights today will be invaluable as we reflect on the complex interplay of neurology, mental health, and community-based care. On behalf of Indian Association of Community and Family Medicine, I thank you all for your participation. Let us use this platform to learn, question, and reaffirm our commitment to making dementia care in India, and especially Alzheimer's care in India, more inclusive, evidence-based, and humane. With that, let us begin our session. Over to you, Dr. Chan.
Thank you, Dr. Ria, for such a warm and kind introduction. So we'll start without further delay. So she already mentioned about little bit the epidemiology, the current theme of this year's Alzheimer's Day. And to start with, Alzheimer's, although it's majorly a part of neuropsychiatry, but I believe that it should be managed not only by psychiatrist only, both the general physician and other people, and as well as the common role of community medicine is also very much important. Here in today's discussion, I'll try to discuss about different type. Alzheimer's is on one type of dementia. There are other types of dementia, as Dr. Ria already mentioned in his introductory speech. So I'll try to discuss as much as possible regarding Alzheimer's and little bit about other types of dementia also. Here I will try to discuss about clinical features, the points that should be notified by the not the medical, non-medical, like non-medicose persons, patients, caregiver for them, and also few of the management points that will be discussed. So to start with, it's not moving right now. Okay. So key takeaway point that to spot the early warning signs quickly in clinic and as well as by the caregivers. Also, what are the first line investigation that should we shall take care when we are getting a patient if we are suspecting of the person may having any type of cognitive decline, majorly Alzheimer's, and also the evidence-based management or whether it is necessary to referral for general physician. Also support the family members with some practical non-drug related strategies. Obviously, the medical part will be dealt by the physicians, but we can educate family members regarding some non-drug or non-pharmacological method that will help them to cope with the Alzheimer's disease. And also some newer aspect that has been going on currently in research domain, currently in last 5 years, and in some future which is like upcoming future, some of the diagnostic tests, some modifying therapy, those which are coming for management of Alzheimer's disease. So to start with the epidemiology and the burden of Alzheimer's, already it has been discussed by Ria ma'am, but I will take it little bit short. In quickly, I will discuss. So the worldwide number is 36 million for all the dementia and Alzheimer's disease, as she also told, like it is almost 60 to 70% of all the dementia. So although there are other types of dementia, Alzheimer's consists of major part of the dementia. And worldwide 55 million people are living with dementia, and it is projected that by 2030 the number will raise to 78, and by 2050 it will be 139, almost crossing 1 billion, which is also a serious concern. And if we see that 6% of the people aged 65 years or older, they are having dementia. So if we calculate the number in total, so we can get like almost every 3 seconds, one person is developing dementia in all over the world. Now, problem with our country, like in India, comes under low and middle income countries. So here the growth is in rising trend. So that is a problem because our population is aging slowly. So by 2030 or 50, we'll get more or more number of older older people, older population, and simultaneously with older population, we'll get more and more number of patients suffering from dementia. Now, this is the last study in 2016 about this dementia. And here we can get, like in India, it is like almost 1.1 11 lakh people, sorry, 1.1 crore. 1.1 crore people are suffering from dementia. And in West Bengal, we can see the number is 92 lakhs. And if we see the majority prevalence, if we get the population wise prevalence, so Jammu Kashmir comes first, which have like 11.04% of the prevalence of persons suffering from dementia in Jammu Kashmir state, followed by Himachal Pradesh. Whereas almost all the states have like almost 6 to 7% in prevalence of people who are suffering from dementia. Now, what are the problem that problem that lead us to this increasing trend and that people are not coming to us? Because there is delayed help seeking behavior in the patient and the family members, because there are stigma and there are low awareness also. And in India, we have seen the care mostly it is by the family base. They don't come to the like to the medical setup, and also our current medical setup, it is not ready to handle that much of people to take care of, because most of the time this dementia care or Alzheimer's care are conservative and it takes time. It takes longer time. It needs multidisciplinary approach. Not only the doctor, other people are also needed to take care of a patient suffering from dementia. And that's why there is high caregiver strain, because most of this multidisciplinary approach, people may come to the doctor and doctor might prescribe the medicine, and other part of the management that is mostly managed by the caregivers or the family members. And that's why in India there is high caregiver strain, and also there are some out of the pocket costs also, because although government setup is there, but it is the government setup is not ready to take care all of the things that for the that is needed for the management of dementia. We have different type of public programs, advertisement, awareness programs, but it is not covering enough all the areas, and also awareness is also very low, and that's why also people comes later phase in dementia or in Alzheimer's, and that also increase the burden of cost. Also prognosis become gradually, if we come with later time, so prognosis become poor. Although government setup is there, NPIC centers are there, so their screening is already is going on, and referral caregiver support, these things are already going on, but these NPIC centers are not enough to cover all the areas in India. Now it's important not only for the doctors, it's important for medical professional and also the caregivers, that recognizing the early sign of dementia. So you check, this is for medical person. So you check in the patient who are coming with complaint, and you ask the family members too if they are getting this type of warning signs. So this might be suggestive of that these patients are maybe suffering from dementia. So the important warning signs here are like new short-term memory loss that affecting daily tasks. So patient maybe previously can do his like eating by self, dressing by self, bathing and cleaning his bed and other things by self, and now persons may be forgetting whether he has eaten or not, and maybe in complicated dress he cannot wear the dress, or maybe he kept his watch, spectacles in some places, and then he forget. Next important warning sign is repetition. So he is asking same question again and again, or maybe misplacing items. So this repetition, what happened? Sorry. In case of repetition, what happened that because the person is forgetting, like the new memories, like near recent memories, that I will discuss the different types of memories. So as the person is forgetting recent memories, so he asking the same question again and again. So if we see in some person that he is asking the same question again and again, so this might be a sign of dementia. Finding pause or losing the thread in conversation. So person is talking and then suddenly he paused for sometimes. So that may be a warning sign for dementia. Then getting lost on familiar roads. Person go out from his or her home and then he cannot come back. Or maybe confusion in seeing the clock. He is seeing the clock but cannot say the exact time. Or maybe phone confusion. He cannot dial a particular number, maybe forgetting the numbers, the common numbers. Nowadays, most of us don't remember phone numbers. It is already saved in our device. But few of the numbers we can remember, and in case of emergency, we can dial. But in persons with dementia, so they might be having forgetting common or important phone numbers. Then there will be reduced judgment capacity, and that's why older people, they have high chance to come across with a scammer, so financial problem, or in medicine also, if they are suffering from multiple other medical illness, and they might forgetting, or they might confused with the medicine and take medicine which is given for morning time, he is taking it at during noon time or afternoon or maybe evening, or maybe one tablet was needed, he is taking two or three medicine. So this reduced judgment can be another warning signs for dementia. Next, not in every cases, but many cases, we can see the personality or behavioral changes. Also, apathy means there is reduced emotion and irritability. Person who was like behaving normally with patient, with family members, with others for like last 60, 65 years of age, and suddenly, if we find that the person is becoming irritable in minor issues, so this can be a sign of dementia. Then there is neglected self-care or loss of initiative. So person suddenly become, if a person was like before 60 or 65 years of age, he was working and very much active, and suddenly if we found that he is not working much, he's most of the time sitting and like spending his time without doing anything, so that could be another sign for dementia. Next, functional decline. Functional decline is like for female or housewife people, women. So might be like there is not a good, like there is decline in doing cooking or banking or other anything job the person is used to do in his daily life. There is decline in this function. So that can be another sign for dementia. Then obviously if a person after 60 or 65 years of age develops some psychiatric symptoms, so usually depression, anxiety, or paranoia is like psychosis, like suspecting someone's without any valid reason. But this depression usually it comes under, like it comes in 30s, anxiety also in 20s or in 30s, psychosis also comes in like early 20s. So this is the usual age, mean age for this having this type of disease. But if we found that a person was perfectly normal until 60 65 years of age, and then he's suddenly developing this depression or anxiety or psychosis, so that could be another sign for dementia. And another one, this family concern, that not their usual self, person is not the same person he used to way act, used to behave, used to do, used to interact with them. So that this sign, this could be another important warning signs for dementia. Now, for assessment of dementia, this table I have taken from this clinical practice guideline by IPS. So, majority of in India, majority of the neuropsychiatric problem, they follow this IPS guideline. IPS is Indian Psychiatric Society. So, Indian Psychiatric Society, they publish this guideline for different type of neuropsychiatric disorder, be it dementia or depression or any. There are many psychiatric disorders. So, I took this table from this CPG published by IPS for assessment for dementia. So here they are saying ki you first check for the signs and symptoms of dementia. Then two of the important psychiatric disorder that their signs and symptoms are also might be make you confused, that delirium and depression. So we should always, if we are suspecting dementia, we should always rule out whether the person is suffering from dementia, delirium or depression. Then also look for other medical problems. Maybe these signs of dementia can be because of some reversible cause, some other medical problems that may lead to this decline in memory. So we should also check for other medical problems. Then we should assess the cognitive symptoms. We'll discuss, there are different scales to assess the cognitive symptoms. Mostly the screening scales used widely in India and all over the world is MOCA, Montreal Cognitive Assessment Test, and obviously MMSE. So we can use these scales to assess the cognitive symptoms. Both of the scales consisting of various type of tests that check different type of cognitive domain, and it like there is total score is 30, and like if there is below 26 in MOCA, so we take it as like suspect that the person may have cognitive decline. Also, we should assess for the non-cognitive behavioral and psychological symptoms, as in dementia, it is very common that person may have depression or psychosis. Then rule out other mental health disorder if the person is suffering from depression or schizophrenia or other psychotic disorders from in the past. So in future, they might have this cognitive decline. So we should also check whether the person is already suffering from any psychiatric disorder or not. And another important is substance use. And then the last part of this assessment is assess care arrangement and need for the carers. Now, these three are very important, closely interchangeable term we use. One is normal aging. Another one is mild MCI is mild cognitive impairment, and another one is dementia. So nowadays, the psychiatry guideline is DSM-5 and published by the American Psychiatric Association, and the ICD, which is published by WHO. So they are referring this term dementia as major cognitive impairment, because the term dementia, it means there is dementia means loss of memory. But it has been found that in dementia, it is not only the problem with the memory loss, rather than memory, there is cognitive decline. And that's why they are saying if there is mild, so they will say it's mild cognitive impairment, and if there is majorly cognitive impairment, they will say the disorder as major cognitive impairment. It is previously known and or maybe widely known as dementia. Also, we can see normal aging people will have the functional and cognition and other decline. So that's why it is very important to differentiate between these three terminologies. So normal aging, we can see the memory maybe occasionally forgetful of names, and then he recalls it later. But in mild cognitive impairment, there will be frequent and noticeable forgetfulness. And in dementia, definitely there will be severe disruptive memory loss and forgetfulness in major event or forgetting the major details. So daily life, if a person is doing aging normally, so he will be fully independent. He can do his personal work by himself. In minor MCI, minor cognitive impairment, they will be mostly independent, but might need some help from the caregivers or family members to uh, to like complete his normal day-to-day life task. But in dementia, he will be totally dependent on others. So awareness means awareness about his illness. So if in normal aging there will be some problem, person is aware about the illness and he's not much concerned about that. But in MCI, the person will be aware and concerned about that there are cognitive changes. And in dementia, often person become unaware that he is having some illness. And if you ask, he will say some big problem, maybe I am having headache or stomachache, this type of problem. But if we like talk with the family members, they will say this forgetfulness and decline in daily functioning. So progression in normal aging, progression is stable. So person aging normally, so there will be stable progression of like forgetfulness or the awareness, other things. And in MCI, there will be transitional progression. And in dementia, the progression will be very high, rapid, and it is irreversible. And if we go like the complicated or like the complicated cognition or higher mental function, so here we get like the problem solving skill. So problem solving skill, the day to day life, like managing finances, banking, or maybe cooking some complicated dish, so they can manage by themselves usually in normal aging. But in MCI, there will be increased difficulty with cognitive tasks. And in dementia, definitely we know that there will be severe impairment and the person will unable to manage all those complicated problem solving skills. So now important is the clinical features. Clinical features, here I will discuss the memory. So as we know, the memory, we can broadly divide the memory as sensory memory, short-term memory, and long-term memory. So whatever we are getting, we have 5 sensory organs. So like visual, auditory, taste, touch, and olfactory or smell. So we are getting different type of sensation from the external environment. So hearing something or seeing something, that makes a rapid fast change in our neuron, so that is called sensory memory. So many a times, suppose we are seeing the slide and there are many words it is written, so all of the words we can like it is visualized by our retina and it is stored in our olfactory cortex. So this is sensory memory, but not all the sensory memory is stored for long, and that's why even we see the slide and all those what most of the things we forget, because this sensory memory never converted to the next part of the memory, that is the short term memory, or we also say it as working memory. So for working memory, short term memory is also known as recent memory. So recent memory or concentration. So if we have sustained attention in some picture, some word, for a little bit longer amount of time. So then that sensory memory will convert it to short term memory. And that's why I like the way I am discussing this picture for long period of time. And if you are listening or seeing the pictures for long period of time, there is high chance that you will remember it. Rather than when I have discussed the epidemiology part, I have shown many states data, many prevalence rate, many total population rate, many estimated population rate. But as we may have seen all those things, but we forget because we did not give enough time to see or to watch or to hear about that slide of the epidemiology part of the dementia. Now coming back to the point, so the recent memory, it is, or working memory, it is it's sustained for like less than 1 to 2 minutes. And this recent memory, and another last part is the long term or remote memory. Remote memory is also divided into implicit and explicit memory. So these are all you already probably know, so I'm not going into details. So now in dementia we are mostly focusing second part, that is short term or recent memory. So in dementia mostly there will be impairment or loss of recent memory, and if the dementia persists for longer amount of time, then we can also say that there will be impairment in remote memory also. Now maybe your question will be that in which type of disorder this sensory memory that will get lost or that will be disrupted. So there is another variation that I have just discussed in few slides back, that if you are suspecting dementia, we should always rule out delirium and depression first. So in case of delirium, there will be loss of sensory memory. So in delirium, in delirium there will be loss of sensory memory, and in dementia there will be loss of recent memory or short term memory. And if there is chronic progressive dementia, there might be loss of remote memory too. So now again come to the Alzheimer's. So the Alzheimer's also divided into typical and atypical variants. So typical variant is clearly mostly amnestic. Amnestic means clear evidence of decline in memory and learning and at least one other cognitive domain. So in cognition, memory is one type of cognition. Apart from memory, attention and concentration, orientation, intelligence, problem solving skill, abstract thinking, judgment. There are many other domains of cognition too. And not only memory loss or decline in memory is suggestive of dementia or maybe Alzheimer's, but also apart from this loss of memory, there will be at least one other cognitive domain decline. Based on the history and testing, we can check that what other cognitive domain is declined in these persons. So these are the typical variant, and majority of the cases will of the Alzheimer's will get this typical amnestic dementia. And there are some atypical variants of Alzheimer's where in posterior cortical atrophy we can see there is a problem in the visuospatial formation. And then there is logopenic aphasia where there will be difficulty in language formation, and the frontal variant where we will find that there will be behavioral abnormality. Now I am discussing very quickly in short other types of dementia. So the major and most common type of dementia is definitely Alzheimer's dementia. Apart from that, the second most common type of dementia is this vascular dementia. So vascular dementia, usually there are if there is hypertension or cardiovascular disease, so there is high chance of the person will get vascular dementia in future. So in vascular dementia, there will be stepwise decline, there will be some focal neurological sign, there will be gait disturbance. Next important type of dementia is dementia with Lewy bodies. So there will be fluctuation in course, there will be visual hallucination, there will be REM sleep behavior disorder, maybe Parkinsonism is there, and in this type of dementia, they are highly sensitive to antipsychotic therapy. Next important part is Parkinson dementia. So Parkinsonism is another neurological problem which is also chronic with chronic disorder with poor prognosis. And in Parkinson disease, if there is in Parkinson disease dementia means the disease started with Parkinson's and followed by, after sometimes, usually it is more than 1 year, so after sometimes the person get dementia. So this dementia is called Parkinson disease dementia. And all the dementia mostly starts after 60 years of age, but if there is younger age of onset with behavioral or language changes, So then we can suspect the frontotemporal dementia. And another type of dementia is normal pressure hydrocephalus. So there will be in NPH there will be gait disturbance, urinary incontinence, and cognitive decline. Now we should check some potentially reversible causes for dementia. So most important type and most commonly comorbid illness with dementia is depression. So depression is also known previously as pseudo dementia because signs and symptoms of depression closely mimics with dementia. So if there is depression, so we have to check and we have to treat depression, and that might reversible the memory impairment and the cognitive decline. So depression is common reversible cause. Another is medicine induced. Mostly drugs with anticholinergic activity, they can cause this memory loss or cognitive impairment. So maybe the cause is medicine induced. So in that case, we have to reduce the dose or maybe withdraw the medicine and suggest some alternative. So that we can like check. And next important reversible cause is chronic disease. So like renal failure, hepatic problem, malignancy, GI disorder, some chronic infectious cause such as HIV or syphilis. So these can be lead to this memory impairment. In that case, we have to take care or manage the like chronic disease. Also, chronic metabolic derangement, sodium, potassium, like hyponatremia, hypokalemia, hypernatremia, or magnesium. This deficiency or this derangement that may lead to this memory impairment. Another important cause is thyroid disorders and some vitamin deficiency. Among those, thiamine, methylcobalamin, and vitamin E are the most common type of vitamin deficiency, which may lead to this cognitive decline. And in all those cases, we have to treat the primary cause to reverse the memory or cognitive decline. Now, important evaluations and investigations. So, for first step of primary care, like first we have to take the history from the informant, and then we have to check for the medication review because I told like maybe these symptoms are coming because of some medicines. So usually in older patient, we can see that most of the older age group, older population, they are having different types of medicine from the past for long years, for 10 years or maybe 20 years. So we will also check about the medicines, and then we'll check for the depression screening because depression is the most common comorbid illness with dementia. And then we can do the cognitive screening test, that MOCA or MMSE. So MOCA or MMSE, these are very useful tests to check the cognition, and it's freely available in the internet. And although MMSE now it has been licensed, but MOCA it is still freely available. You can get the MMSE and you can use it, but you cannot publish the data without like having, because they will strike the copyright. But the MOCA is still free. So MOCA or MMSE, we can do the cognitive screening. It's very basic type of screening test, and it will hardly take 10 minutes, probably not more. So within 10 minutes you can do the cognitive screening, and if we get like less than 26 in MOCA and less than 24 in MMSE, so we can suspect there is cognitive decline. And there are like three variants: mild, mild, moderate, and severe cognitive decline based on the number. And based on that we can like do a quick cognitive screening. Then we'll check the ADL. ADL means activity of daily living, and instrumental activity of daily living. So we can check the daily living means the functioning. So whether the person can brush, wear clothes, like maintain hygiene, or all do the daily day-to-day life of work, whether he can do by himself or not. And instrumental activity means like where we need complicated machineries like driving, or maybe doing banking job, managing finance, or like doing some complicated work. So this in instrumental activity of daily living, whether he can do perfectly by independently by himself, or he is needing help for that, so that we can check. And then we'll also rule out the delirium, check vitals, and do the neurological examination. So these are the first step in primary care setup. And then few baseline lab investigation that we should do. One is CBC. CBC is important to check whether there is infection is there or not. also to check the hemoglobin level, and then electrolytes. So because we have discussed already that one of the reversible cause is like metabolic derangement, and then renal and liver panel to check whether there is chronic disease is there or not. Then glucose or HbA1c to check whether the person is suffering from type 2 diabetes. Similarly, the TSH level to check whether there is hypothyroidism or thyroid dysfunction, followed by those vitamin levels, B12, folate, and lipid profile. Also to check the infectious cause like HIV or syphilis. If it is not like regularly, if any patient comes with like this memory impairment, we will not do regularly. But if we find that there is risk factor present, or if you are like suspecting clinically this might be a case of HIV or syphilis, then you will always do the baseline lab investigation like the serology test. And also if we suspect that the person may be suffering from depression or anxiety, so we'll check the depression, and we use the depression and anxiety scale. For depression there is HAM-D scale, and for anxiety there is HAM-A scale. HAM-D is Hamilton Depression Rating Scale, and HAM-A similarly Hamilton Anxiety Rating Scale. So in those scale, that will also hardly take 10-15 minutes to conduct, and based on the result we can suspect whether the person is suffering from depression or anxiety. Now imaging is also necessary, and as per the guideline we should do the brain MRI. But as we know, like a majority of the India rural or in semi-urban setup also, MRI is not available. Many a times it is costly. So CT we can also do. In CT usually we get the cortical atrophy. So if there is cortical atrophy in CT scan, that means it is suggestive of dementia. But CT scan is not much helpful to find the cause, whereas MRI is better than CT scan because it helps us to find the cause. So in MRI, we'll check for the vascular lesion, and then if there is tumor, normal pressure hydrocephalus, or there may be any hemorrhage or infarct. So that we can check in MRI. And also I am discussing few of the biomarkers that has been come from the research level, but it is not widely used in India. In fewer part of the India, mostly in like the metro city level, they check this CSF, all those proteins, tau proteins, A beta 2, 40 proteins, amyloid proteins, and by checking this Alzheimer's disorders disease pathology. And apart from CSF, there are some blood-based biomarkers are also emerging, but this mostly is done in by research purpose or few of the very high-end hospitals where we get this type of testing. Now the important part is the management of the patient suffering from Alzheimer's. So the important priorities in primary care setup is to explain the diagnosis and also to address the stigma and involve family members as early as possible. Then the important part is treatment of the reversible contributors like delirium, depression, hyperrem, that has been already discussed. And if there is factor is present, so aggressively manage to reduce the burden and reduce the severity of dementia, such as hypertension, diabetes, or derangement of lipid profile. Also, like if the person is like having any kind of addiction, that will also to be managed aggressively, and also encourage or promote exercise. Then home safety, and also tell the family members about the problem with driving and the wandering behavior. Many a times because of forgetfulness, people comes out from the home and he does not get back because he forget the way back to home. So this thing also should be told to the family members, and also to the advanced care planning if it is necessary. So first about the non-pharmacological management. So education and caregiver training about like how to communicate, what are the cues, the warning signs, and like to do the daily routines properly. And then there are fewer therapies, cognitive stimulation therapy, occupational therapy for dementia patient, but most of the time this is managed by the psychologist. And apart from that, patients should be engaged in physical activity, in social engagement more to reduce the like to increase the functioning level. Also, if the person with aging hearing or vision problem, so that should be corrected. And sleep hygiene also to check and manage pain if there is pain for some chronic illness, constipation, and to also to check the anticholinergics. Also, the behavioral symptoms should be checked before approaching for any drugs. Now again, about the pharmacological management. So pharmacological management, this I have taken from the NICE guideline. So here they are saying the first line of drug should be this cholinesterase inhibitor in dementia. So important drug is donepezil, and usually we start with 5 milligram, and maximum we can use 10 milligram per day. Donepezil, in my personal experience, it's a very good drug, and if there is no other comorbid symptoms with dementia, mostly it's Alzheimer dementia, clear cut memory loss and cognitive decline, donepezil works good. But problem with donepezil that it many a times cause nausea, vomiting, and muscle cramps. And if we use, we should give it always after food to reduce this side effect. And if it is well adjusted and well tolerated by the patient, it works fine. So donepezil is usually we use in day-to-day practices. Apart from donepezil, there is rivastigmine. Rivastigmine patch is also available. Rivastigmine, we start with 3 milligram, we can go up to 12 milligram. And but rivastigmine has a little bit more side effects, and that's why it is not preferred as first line agent. Or you can use rivastigmine patch also. In rivastigmine patch, there is like less side effect with rivastigmine patch. Rivastigmine patch, we can get like 4.6 milligram patch, and we can like extend up to 9.5 milligram. Donepezil also there is extended release, although I don't have much experience on using this extended release donepezil. I think this donepezil, normal donepezil, it works fine. Also, another important and very good drug if there is dementia or an associated some of the psychiatric symptoms, because majority case of Alzheimer's or any other dementia, highly likely you will get psychiatric symptoms associated. So there memantine, which is NMDA receptor antagonist, it works better compared to donepezil, and many times we use this combination therapy like donepezil and memantine in combination. So memantine we can start with 10 and we can go up to 20. And in my personal experience, memantine single therapy is also as good as if you compare to like this combination therapy, donepezil plus memantine. And good thing about memantine is it is very well tolerated, not much of a side effect. And it's as we know that for in dementia you have to take the medicine for lifelong. So that's why if there is less side effect, there is high chance that patient will continue the drug. And if there is high side effect, there is high chance that patient will discontinue in later phase of his life. Now, one important part from the psychiatric perspective from in dementia, there is behavioral and psychological symptoms. Also, it is shortly we write it as BPSD. So there are some behavioral symptoms and psychological symptoms that comes with dementia. So in that case, we should check for the trigger factor. Why there is some like irritability, anger, outburst, shouting, all of a sudden in a patient suffering from dementia. So to check for pain, whether any infection is there or any environmental cues that making the person triggering to do. So this is called BPSD. So we'll first do the non-pharmacological therapy like listening, listening to music, then activity scheduling, then a good amount of sleep. These are important part. But if there is like urgent or there is severe risk, so we should always start the atypical antipsychotic. But before starting atypical antipsychotic, we should discuss the risk benefit ratio, because there may be sometimes faults are there, high risk of mortality is there. Antipsychotic always come with that black box warning that antipsychotic cause sudden cardiac arrest in old age group. And although I have not found, it's very rare, but you should always discuss the risk with antipsychotic. So few of the important antipsychotics that we use to manage this BPSD, if there is paranoia is there, or like agitation is there. So we use in very low doses. In very low doses, we use so risperidone 0.5 milligram, olanzapine 2.5 milligram, and quetiapine 25 milligram. We start, and maybe it can be increased up to 1 milligram for risperidone, 5 milligram for olanzapine, and 200 milligram for quetiapine. So this is for psychosis or agitation, and many times we used mood stabilizer also. That too also very low doses, divalproate or carbamazepine. And if we are suspecting depression or anxiety in patient with Alzheimer's, so we can use citalopram, escitalopram, paroxetine, or sertraline. Mostly in clinical practice, we use escitalopram. We can also use paroxetine, but chance of sedation is more with paroxetine, and we may use sertraline, but chance of metabolic derangement is high with sertraline. So, based on the side effect profile, so although it is recommended, you can use any of the four, but my preference is always using escitalopram. Now important part is to check other things, like if there is comorbidity, like some medicine with anticholinergic burden, so we de-prescribe the medicine if it is possible. And then if there is chance of fall, then we should check whether the person is vitamin D deficiency or not. Then we give that type of medication, and also we do the physiotherapy. And for nutrition, there is mind or Mediterranean style diet, where there we use the photo is there with the slide, that what are the important food that is useful for brain. So eggs are there, berries are there, green salad is there, beans, poultry, fish. These are important, some of the few important food. This will help in improving or charging brain. Next, about quick recapitulation of other dementia. So vascular dementia, it is usually like associated with hypertension or diabetes. Then dementia of Lewy body or Parkinson dementia, this is mostly under recognized, and there is high antipsychotic sensitivity risk. Frontotemporal dementia, although prevalence is low, but there is major impact in the economy and the caregiver, because it's usually younger in onset. And normal pressure hydrocephalus, although it's rare, but it's treatable, because if we do the shunt, then we can like cure the normal pressure hydrocephalus. Now about future direction. So in future direction, what are the current studies that are going on like management and other things. So like planning of the research is going on to make the wider availability of the biomarkers, that I have already been discussed, that there are few biomarkers are there. Blood biomarkers are there, CSF biomarkers are out there, but these are mostly available in like top metro cities only, and that too in few of the selected hospital. So the wider availability, this is in discuss. And then the care model means integrating primary care health setup, daily health setup, and the caregiver training together. Next, there is home-based and long-acting formulation for disease-modifying therapies. Those are in near term. These are the future plan in management of dementia. And there are some other plans, not in near term, but maybe in upcoming 10 years it will come, like the combination therapy of anti-amyloid, anti-tau protein. Then the risk profiling using like polygenic gene checking or vascular profile, all those, or maybe digital biomarkers to monitor. These are all newer research aspects. These are coming through hopefully within next 10 years to manage the patient better. So these are the some quick recapitulation. So like patient comes, so you will do the CBC, CRP, HbA1c, TSH, B12, folate, that has been already discussed. Lipid profile and ECG. Imaging, MRI brain preferred, but if it is not possible, then CT scan is also okay. And then depression screening, sleep apnea screening, hearing and vision check. And it is also important for primary care physician, like when to refer urgently if you find that there is rapid progression of the impairment of memory or cognitive declinement, there is prominent neurological signs, there is seizure, so it's better to treat in higher setup. Otherwise it's okay to manage patient of dementia in primary care setup. Also, if there is younger onset, which is in frontotemporal dementia, or maybe there is atypical type of presentation, visual language or behavioral variants that I have discussed about some other atypical variants of Alzheimer's. So then it is important to refer. And in secondary causes, reversible, although it's reversible cause, but if there is tumor, brain tumor, normal pressure hydrocephalus, or in some in autoimmune disorder or infection, so it is also better to refer. So clinical checklist. So check the MOCA and MMSE ADL screening, lab test, imaging, medication to review, safety screening about like educate the family members and the person about driving, about fall, about financial risk, and then caregiver education and follow up. So now there are few of the case that it comes like that way. Like so, I'm discussing few of the cases. So, like a 68-year-old female. So there is memory lapse for 1 year. So he is having repetition of questions, misplaced items, and increasing difficulty in doing his day-to-day life work for past 3 months. So we check there is no major depression, and in MOCA scale there is 21/30. So I already told that less than 26 you always suspect for dementia. So it's not like normal aging process. It is not. So because there is progressive decline, and apart from progressive decline, there is ADL means the functioning is problematic. So if there is functional impact, so we'll suspect definitely for dementia. And based on this clinical case, we can think of there is mild Alzheimer's dementia. Next, another case like 72-year-old male, there is sudden change in the personality. Then there is apathy, financial mismanagement. However, he is oriented, memory is relatively preserved, but family notes disinhibition in his behavior and loss of empathy. So here in this case, we can consider as this person as frontotemporal dementia. Next, another one is 74-year-old male. He is already suffering from diabetes and hypertension. There is history of stroke, and there is stepwise cognitive decline. There is gait imbalance, and there is executive dysfunction. So if we are finding this type of clinical case, we may suspect of vascular dementia. So I think this much for today. So I hope I tried to discuss as much as possible with this time about the various clinical features, about the warning signs, about the some investigations and the management issue uh, as in whole. Thank you.
Thank you, Dr. Chayan. That was a very rich description of how to detect and manage dementia patients, Alzheimer's patients at the level of primary care and maybe in secondary care as well. Because, as you rightly said, all the uh, blood tests or the biomarkers or even MRI are not, fully available in the peripheral setup, even in this semi-urban, the peri-urban setups also, in some cases. So that is very worrisome for the primary care doctor in that way that I maybe through clinical examination, maybe through tools like MOCA and MMS, he can understand that there is dementia. But what kind of dementia? Is it associated with depression, anxiety, or any other thing? So becomes very difficult and challenging for that doctor. Then the person has to refer the patient to the higher setups, and maybe sometimes the patients cannot go to the higher setups because maybe of many other socioeconomic problems. So that becomes a very challenging case for both the physician and the patient. And especially in today's India, there is rise of the geriatric population. Mostly the geriatric people, they tend to go to the primary physicians only because sometimes the caregivers or sometimes they don't even understand what is wrong with them, so they cannot go to a specific doctor at first. So obviously it is a very important task for the primary physicians to understand what is dementia, how can it present, and how to manage them at the primary level to the best of their ability. And after that, even after that, if it is not manageable, or if there are warning signs, like you mentioned at the end of your speech, that when to refer to specialist or higher centers, then the primary physician should also be aware of when to refer them, so that the patient gets prompt care. So thank you for that, Dr. Charan. And we learned a lot of things new, maybe refreshed for us. That is, there is not only memory decline in Alzheimer's, there is cognitive decline as well. And there are many other common causes like vascular causes which can present to us in the role of dementia. And maybe dementia reversible as well. We just have to look out and test for the basic investigations and see whether they're eliminated or not. So thank you for that. If anyone has any question, they can write in the chat box, I guess. Is it
Ma'am, we haven't received any queries from the participants, ma'am.
okay. Not yet. Maybe we can give 2 minutes for that, and after that we can see. Um, I just want to ask Dr. Choyon that have you seen any like unmanageable case of Alzheimer's or maybe dementia in your practice that you had to refer to maybe a tertiary higher center because it was even unmanageable, or maybe severe case in that case? Can you just maybe give us an example from your practice?
No, I have seen many cases, probably not any case, okay, many cases of unmanageable dementia, because the problem with the dementia management, if we specifically focus on Alzheimer's also, it is not a single person's approach. And that's why I'm glad that this invitation has come from like community medicine, because case of dementia, not only medicine. Am I audible? Okay. So
Yes.
okay. So not only medicine is important. Okay. Apart from medicine, this caregiver education, the management of daily life functioning, these are also important. And many a times, because of the stigma, because of the poor awareness, so it's become difficult for the patient's family members, because patient is grossly unaware about his situation. And the family members, they want ki you give some medicine, after that within 5 7 days or 10 days, person again start remembering everything. And as we all know that this is a like chronic and progressive type of disorder, so even with medicine there is high chance that maybe without medicine the person may progress or may deteriorate within 5 years. But with medicine, this donepezil, memantine, rivastigmine, that we have already discussed, or already we have seen in the slide. So with those medicine, you can increase the term of decline. So maybe without medicine, person may decline totally within next 5 years, but with medicine, you may increase this with 10 or 15 years more. And to survive that person with the next 10 or 15 years in his life, we need family members support and other things, which is grossly lacking, I think, in India. And that's why management become difficult in that case.
Yes, very truly spoken. We also sometimes do not think about the caregiver's point of view. And there is I think there's a space between the tertiary treatment at hospitals and the primary treatment at home. There is something in other countries called hospice treatment, where they are taken care long term, but like they are not taken care by in a hospital setup like ICU setup or any other ward setup. They are taken care for long term, and maybe that is required for, especially in cases where the caregivers are not understanding that how else can I take care of my patient, of my family member in this case, because uh, everyone is busy in their lives, and it is very difficult to keep an eye on 24/7 on such Alzheimer's and dementia patients. So sometimes they are even confused, and they are also waiting for some miracle treatment so that it gets better. But as we all know, Alzheimer's is a progressive disease. We can only slow the progress, we cannot stop it. So that is a very important thing to keep in mind. And all, and as you said, we should always collaborate with each other and get more knowledge and have a more better handle on how to manage our patients, which can come in every one of us as physicians. So for that, I really thank you, Dr. Charan, for joining me and Clarnet in this evening session. It was a very good insight into Alzheimer's and dementia, and thank you for that. I would also like to thank the opportunity given by Clarnet to host this, that they hosted this session on the platform. And finally, to the participants and my team members of IACFM who have supported through all this time for successful conduction of events like this webinar. So thank you, Dr. Chan. Thank you, Clarnet. And with this, I think we can end this evening session.
Oh, thank you for the
Oh,
opportunity. So we'll like to collaborate more in the future if possible.
yes.
Okay, okay, okay. So like we're
Okay. Okay.
signing off.
So,
Okay.
thanks
Thank
to
you.
all the dignitaries present here. Client is really glad to have all this brilliant people together in this session today. And I really hope that you all had a seamless experience. So, with everyone's permission, I am concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you.
Thank you. Good night.